All right, Chairman Harrell, we are live and you have the floor.
I'd like to welcome everybody to the first Pitt County Board of Health meeting in 2021. We are all virtual, nobody's on site. So everyone, please be patient with us. We'll go ahead and call the meeting to order and have a roll call by Ms. Betsy Wallace.
All right, thank you. Chairman Adam Harrell.
Present.
Vice Chair Tina Dixon.
Present.
Martha Engelke. Rex Fleming.
Present.
Herbert Garrison.
Present.
Mark Hayes.
Present.
Scott McIntosh.
Present.
Natish Patidar. Kelly Pack Smith.
Present.
And Lowell Spate.
Present.
Thank you. We have quorum.
Next, we'll see or hear any public comments. Seeing none, we'll move on to the minutes from the previous meeting. They've been circulated by via email to all of our board members. Any questions or comments from the board members regarding the previous minutes meeting? Seeing none, we will look for a motion to approve.
So move.
Second.
Any further discussion?
I'm sorry, I didn't catch who made the motions.
Mr. Fleming,
And who's second?
I think Dr. Garrison.
Yes.
Thank you.
If we don't have any further discussion, we'll move on to the fiscal report with Ms. Marsha Hall.
Hey, everybody. Hope everybody's doing well. Happy New Year. Can y'all hear me okay?
Yes.
Awesome. I apologize for the delay in getting this report. I had the privilege of helping the vaccine clinic yesterday, so sorry about getting it kind of late to you this morning. We are in the middle of this fiscal year, and we did have 2 budget amendments, which resulted in an $85,699 addition to our budget, bringing our overall budget to $13,293,837. And halfway through, we do have, our typical timing items, and we do have some encumbered purchases. We did have 3 payrolls the month of December, and year-to-date adjusted, we are looking at around a $540,000 surplus. And I know that I jumped around just a little bit, but as you can see, the very last column, things that you should be expected is Medicaid to be down. We are doing very little services, only the ones that are mandated due to our COVID response. Our environmental health fees are extremely high, which is more than what we had budgeted for, which is nice to see, even with so many vacant positions. Our state funding is a little bit off, and that is only because we've got quite a bit of COVID funding that we are trying to spend appropriately. There's a lot of different pots of COVID funding, and with the county COVID funding, with testing, we've used that more so than some of our other state programs. And when the state programs are, if they're not spending the money in their program, we can't pull it down. And as far as the other, it's a little running low, but some of our partners were pretty much virtual the month of December. So we're expecting that to catch up any day now. So I don't have any major concerns at the moment, just making sure we spend the money correctly that we are receiving from the state. But at the end of December, we are looking okay. Do y'all have any questions for me?
Any questions from the board members? All right, seeing none, are you ready for us to approve?
Yes, sir.
All right, I'll seek a motion to approve the fiscal report.
So move.
Second.
You have anything else, Marcia?
Just for grants, we've got a couple of grants that end in the end of December, and majority of those were spent out, you know, the way they were supposed to. It was mainly our food and lodging. We do have quite a few positions vacant, but truthfully, all of our response is towards COVID, and there's not a lot more time involved to be able to do much more than what we're doing. But we're hoping that we're on the other side of this. So that is really all that I have as far as the business side of things for the month of December. I mean, there's a lot more detail I can go into, but I'll save you from that.
Any further questions from the board members? All right, thank you, Marcia.
Thank you.
We will move on to items of old business. And seeing none, we will move on to new business. So we got an email from Betsy regarding a conflict for our June meeting. We need discussion with the board members on making a decision on what we want to do. Options are to reschedule or cancel.
What month do we usually, it's either June or July, we usually skip, do we not?
July.
Yeah, we
July.
usually skip in July. I would say we would probably need to reschedule. Hopefully things will be better by June. And if they're better, maybe we can consider canceling later. But I think for now, we probably should go ahead and reschedule.
I agree. I guess what we need to hear from the county are what are available dates that we can hold a meeting, because not knowing when meetings are scheduled, you know, that is going to have an impact on when we can meet.
Betsy.
So I can check with the county schedule and submit to you guys a few options. Do you want to keep them about at 6 o'clock on a Tuesday, or are you more flexible on another day of the week?
Tuesdays at about this time work better for me, but
I will see what's available. I will see what's available later in the second week, and then give an option for a day and time in the third and fourth week of the month so that you can vote on that.
okay. Sounds good.
I'm getting a note that we did not accept the fiscal report. If I skip that, we need to do that.
I have, for the physical report, I have Mr. Fleming made the first motion and Ms. Engelke made the second motion.
You didn't call for a vote, Adam.
Yeah.
My mistake. We'll do a roll call vote with Betsy on that.
So then we would have to go back and do a roll call vote on the minutes as well. I thought we were, okay. So do you want to start with the minutes on a roll call vote?
Yes, we'll do that. We'll accept those and then move to the fiscal report.
Okay, so for the minutes, the first motion was from Mr. Fleming, second motion was from Garrison, So Tina Dixon,
Yes.
Martha Engelke,
Yes.
Mark Hayes,
Yes.
Scott McIntosh,
Yes.
Kelly Pack Smith,
Yes.
Lowell Spate.
Yes.
And for the physical report, Tina Dixon,
Yes.
Herb Garrison,
Yes.
Mark Hayes,
Yes.
Scott McIntosh,
Yes.
Kelly Pack Smith,
Yes.
and Lowell Spate.
Yes.
Thank you.
All right, so Betsy, what we'll do is you'll find some potential times, and then next month we'll decide on a date for our June meeting. Is that how we're leaving this?
Yes, I'll have some available times for you, and you all can decide on what would work best for the board.
Okay, great. We'll do that. All right, next we'll move on to our health director's report with Dr. Silvernail.
Good evening, Mr. Chair. Good evening, Board of Health. I'm going to go ahead and share my screen with you. That's not on my end. And should be seeing, and it says BOC, it should say BOH, COVID update. I apologize for that. I adapted my presentation to the Board of Commissioners last night for you all tonight so that each body has essentially the same information. So first thing I wanted to do was kind of talk through Vaccines 101. While some of us are healthcare providers, not everyone on the board is a healthcare provider, and I thought it might be beneficial to have a brief discussion of vaccines and how we got to where we are with our COVID vaccine at this time. So some terminology: antigen is the part of the microorganism to which our immune system responds. This is usually a protein. The antibody is a soluble protein made by our body, by our immune system in response to a given antigen. Cell-mediated immunity is the immunity that resides in the chemical memory of our immune system cells. So how do we make a vaccine? Well, we need to find a way to deliver the antigen into our body so our immune system can respond to it. The following is an oversimplification of the real process, but I hope you will find it helpful. And I apologize to the healthcare providers on the board for this may be a little oversimplification for you. If you look at vaccines, and this is sort of the Silvernail taxonomy, this is not anybody else's taxonomy. What we might call first generation vaccines involve taking the organism in question, inactivating it in some process, and then processing it into a vaccine. So we would kill the organism or inactivate the organism and make that into a vaccine, which we would then inject into our body to give us immunity. The other part of first generation vaccines involved, again, inactivating the organism, disrupting the organism, and then extracting the antigen from that disrupted mixture and processing that antigen into a vaccine, which was then administered to the people. In the 1980s, what we might call second generation or recombinant vaccines appeared in the marketplace. And in these vaccines, the genetic code for the antigen is inserted into another organism. That modified organism is grown in culture and produces the antigen. The antigen is then extracted from the culture and processed into a vaccine. Many of us, myself included, and probably many of you have had the recombinant hepatitis B vaccine, and this is an example of that type of vaccine technology. Well, eventually people said, well, hey, if we can put the instructions to make the antigen into another microorganism, why can't we just give the human body a message to make the antigen so we can become immune that way? And this was the generation of what are now known as RNA and DNA vaccines. So this concept has been around for a while. And again, rather than extract or grow the antigen, the instructions to make the antigen are given to our body, and the body produces the antigen. Both the two approved Pfizer, oh God, I can't talk tonight, I'm sorry, COVID brain. The two approved COVID-19 vaccines produced by Pfizer, BioNTech, and Moderna are both messenger RNA or mRNA vaccines. These vaccines take the instructions for the COVID antigen, what's known as the spike protein, to our body, and we make the antigen. Our protein producing machinery makes that spike protein from the COVID virus. And then once that antigen is produced, once that spike protein is produced, it's released from our cells and our body recognizes it as foreign and responds, giving us protective antibodies. It's really kind of neat technology that's available with advances in genetic science. And one of the reasons this is available so quickly is that we had the viral sequence, the viral genetic sequence, very early in the course of this pandemic. AstraZeneca is working on what will be the first DNA vaccine for human use. The concept is the same, except the instructions are written in DNA instead of RNA. This has not been approved by the FDA at this time, but is headed that way. Just kind of a brief introduction to the vaccines and how they've been produced over the years, and this new generation of RNA and DNA vaccines that will likely be commonplace going forward. I want to talk about the vaccine that we have. Pitt County Health Department is currently receiving the Moderna COVID-19 vaccine. This vaccine is approved for individuals 18 and older. It cannot be given to people who have received another vaccine in the past 2 weeks. This is really the guidance of the Emergency Use Authorization, and they want at least 2 weeks between the COVID vaccine and any other vaccine. So if you need another vaccine, it can be given 2 weeks or more before the COVID vaccine or 2 weeks or more after the COVID vaccine. They just don't want them in the body concurrently so that the adverse effects get wrongly attributed to the COVID vaccine. They want to try to study that as cleanly as possible. If you are allergic to the vaccine or its components, would be a reason not to have the COVID vaccine. And if you're allergic to polyethylene glycol, which is one of the components of the vaccine, it's a rare allergy. Polyethylene glycol is found in Miralax. It's also found in cosmetics. It's an additive to many, many products that we encounter. It's a fairly uncommon allergy, but my wife is actually allergic to it. So it is out there, and you do occasionally run across those things. The Moderna vaccine is a 2-dose series. Dose 1 on day 0 with the booster dose on or after day 28. And initially this was published as kind of a hard schedule. Day 0, day 28, got to be on schedule, can't be late. And what now they've softened that stance somewhat, and it's really about the minimum space between the doses. So if we need to have a minimum spacing of 28 days between the doses, but if it's a little bit more than that, that is fine. What we are generally doing is pre-booking people to come back for their booster dose at the time of their primary vaccination, so that they don't have to worry about getting in for the booster. I'd like to review our current vaccine operations for you. We continue to host clinics for phase 1A, which are our local healthcare providers, and these are done at Pitt County Health Department. We may shift that location to a larger venue so that we can process folks more folks in a day and with better spacing. We're meeting spacing requirements, but we're at the limits of our capacity and could go a little higher if we had a larger venue. This week, yesterday, we conducted our first phase 1B group 1, meaning persons 75 years and older clinic at the Pitt County Agricultural Center. We gave 224 vaccinations. Everybody that was scheduled came in and got their vaccination yesterday, and we will schedule additional clinics for this group probably next week, pending vaccine availability. We are expecting an additional 600 doses at this point. We thought they were coming on Monday. They did not come Monday. Today I was told they're coming tomorrow. So I'm reluctant to schedule a clinic until I actually have the vaccine in our freezer because I don't want to have to cancel people that thought they were going to get vaccine doses. As I said, we are scheduling the booster dose at the time of the first vaccine. And we're doing a little bit of work to try to consolidate boosters where able. We have not given our first booster dose yet, but we're approaching that next week. We know that the process for the booster dose will be a little shorter than the primary dose, and we feel like we could run more booster doses through a clinic if we do dedicated booster dose clinics. We have some contract staff that are willing to work after hours, be that a weeknight, evening hours or weekend hours. And we'll likely schedule some of these boosters in the evening or weekends as our contract staff allows us to do that. We continue to work to expand vaccine delivery. Again, this is all pending availability. Last week, I met with the City of Greenville Occupational Health Clinic regarding boosters for Greenville Fire Rescue. We would hope to get the complete series for both Greenville Police Department and the Greenville Transit Workers, which are, at the time of this writing, still the next groups up. But that guidance may be changing. So we would like to get those done through the City of Greenville Clinic. Again, that broadens our footprint of distribution and helps decompress Pitt County Health Department run clinics. I had a reach out from Kevin Kaiser at Greenville Utilities about vaccinations for his staff. They would be the 1B Group 3 under the current guidance. And again, that was one of the clinics that I helped run when I was with Biden Occ Health. I will be talking to the nurse there about vaccinating GUC employees when it is their turn. And then the question will become whether we push some Moderna vaccine to them or whether that flows through the hospital stockpile. Have not addressed that yet with the hospital, still working through that process. We're beginning to work with other employers who have in-house occupational health clinics. And again, anything that we can do to decompress the burden on the health department and spread the burden of vaccination across the medical infrastructure that exists in our community is good for everybody. Again, continuing this discussion on expanding vaccine delivery, we continue to work with Vacc Health to coordinate vaccination of eligible group. Work is progressing on a potential joint large-scale vaccination site that would serve the general public. Our operational target is to be able to deliver 1,000 vaccinations per day through that site. Biden, I've been working with Todd Hickey and another group at Biden, which Todd is part of, on this, and he's working on a venue, and they believe they have a direct line to the secretary's office, and that if we are able to stand up a center like this, that the state would be able to supply a vaccine to keep that center running. It's supplied with vaccine. Yesterday, additional providers were eligible to apply through the CVMS portal for the process of becoming a certified COVID vaccinator. At this time, new providers will not directly be supplied with vaccine, but it will facilitate the transfer of vaccine between providers, again, broadening our footprint of distribution. At present, again, I need to stress this for everybody. At present, there's not enough vaccine for every eligible candidate to receive vaccine at the same time. And again, I stress that the burden of vaccination must be spread across our medical infrastructure for it to be successful in this campaign. COVID vaccine scheduling has been a great outcry from the public wanting to be scheduled, even if there aren't available dates yet. They want to be on a waiting list. We've done some work behind the scenes to get this in process. After I finish my report, I'm going to let my Deputy Director, Amy Haddam, describe how this process is going to work. This will go a long ways towards whetting that need in the community and getting folks at least into a database where we can draw them out as clinics are scheduled to vaccinate them. Vaccine prioritization on the North Carolina Department of Health and Human Services call today. It's the local health department call that happens every Tuesday. We were advised that the federal guidance upon which the state guidance is based may be changing in the near future. If the federal guidance changes, the State Department of Health and Human Services will need to decide if it will change the state guidance. If the state guidance changes, this could further complicate vaccine delivery. The tentative timeline published in the 12/30/2020 letter from the State Health Director, Dr. Tilson, may also be delayed in its progression. If you have not seen that letter, I can have Ms. Wallace send that letter out to the Board of Health so you're all have that guidance in front of you. I'm not sure if we had done that already, and I apologize. That's kind of COVID brain right now. Let's take a few minutes. We'll talk through the Pitt County data. I'm going to show you these slides quickly. This is from 1/5. Let you look at that for a second. This is from the data from Sunday when I put my report together for the Board of Commissioners. And then this is looking at today's data after the data was updated today. So over the past 14 days, we've had 2,196 cases in Pitt County. That's an average of 156.9, so almost 157 cases per day. Our active cases per 1,000 residents, I think that's an easier number to understand on the local level than cases per 10,000 or cases per 100,000. And we are right now at 11.9 cases per 1,000 residents. So that's up even from just a couple days ago. Our total case count to date, which is always going to go up until the cycle resets and we start counting for what will likely be the next reporting period. We stand at 13,247 cases in Pitt County, and meant to recalculate that. I still think that is about 7% of our population. 13,47. Yeah, still 7.1% of our Pitt County residents. So that's unchanged from Sunday's calculation. Today, we would estimate that there are 10,982 cases recovered in Pitt County. That represents 83% of cases recovered. We have been holding steady for the past couple of weeks at 69 cumulative deaths. So that is good. As our fatalities stay level, our case fatality rate drops. So our case fatality rate is down to 0.5, which has been the lowest it has ranged throughout the pandemic. Unrounded, it's 0.52, so still trending down in the unrounded numbers. Again, that range is 0.5 to 0.7. By comparison, the unage adjusted flu flu case fatality rate is generally reported as 0.1, and this would also be an unage adjusted case fatality rate for COVID. So roughly about 5 times more fatal than influenza. But we're at the lower end of the case fatality rate range again for the pandemic. That number, by the way, is better than the state and the national case fatality rate number. Our percentage of tests returning positive was actually down a little bit today. We were at 13% even. When I did my numbers for the Board of Commissioners meeting last night, we were at 13.6%, so down about 0.6 of a percentage point since Sunday. So that is at least a glimmer of good news in an otherwise growing and rising indicators. Want to show you some graphs. These come from a report that I get every week. The state NC COVID system provides these. These are county level data, not state level data. So this is not the state. This is the Pitt County epidemic curve on a week-to-week basis. The blue in this chart represents folks who do not live or are not known to live in a congregate living setting. The salmon or orangish color represents the cases that come from congregate living centers. You can see around the end of May, beginning of June, we had an outbreak. We had some activity in the late summer, kind of came down through the fall. Another little bit of one around the beginning of November. But the last few weeks, we have had no cases in the long-term care facilities. I think this is attributable to the protective measures that are in place at this time with the aggressive testing of staff and residents. When they do find somebody that's positive, they're able to wrap around that case, get that case isolated, do the contact tracing, get the contacts quarantined, and control the spread of that in these settings. So right now, our local long-term care facilities appear to be doing a very good job of controlling the spread of this in their facilities. And I think that's a glimmer of hope in these difficult times. This graph, same epidemic curve, but this breaks it down by race and ethnicity. The red box represents African Americans. There's actually been maybe a little bit of a downturn most recently in that. Early on, African Americans bore a very, very heavy proportion of cases. One time we're over 55% of our cases in Pitt County. That with time has come down as a percentage, still heavily impacting the African American community though. The slate blue bar represents whites, and that has continued to grow throughout the epidemic. This sort of lavender or purple, not quite pirate purple, but lavender colored bar represents Hispanic individuals. We have a relatively small amount of Asian or Native Hawaiians, and we do have a box that is known or unknown. Unfortunately, race and ethnicity data is not always included with case reports to the NC COVID system. Same thing, our epidemic curve. Again, this time broken out by age. The yellow represents this sort of yellow or goldenrod color represents the school-age children, 0 to 17. And you can see beginning around the first week of December, there was some growth in that. That fell a little bit the week after Christmas, on the week of the 26th, and then, or the week of Christmas. And then the first week of January, that's back up and even a little higher than it was before. The red represents the college-age students, 18 to 24. These 3 bars in the middle of the graph represent the ECU outbreak, and a very high percentage of 18 to 24-year-olds there. Since that time, that's been relatively stable, maybe slightly increased. Students don't come back, until the 19th now at ECU. But the growth really in our case numbers have been in sort of the young adults, young adult working population, and that's this 25 to 49-year-old group, that's sort of slate blue. And you can see in the most recent week, that was the largest percentage of cases, followed closely by those in the 50 to 64-year-old age group who are seeing some burden of disease as well. The 75 and older age group has always been the smallest part of our case count. Overall cases, about 5% of our overall cases, but unfortunately represent in excess of 50% of our deaths. So a very vulnerable group from the standpoint of COVID. I'm going to move on. This graph shows our percent positivity versus number of tests done in the county. I would argue that there is a spike back here in April where we were calculating this internally, and our internal percentage had hit 21%. Our numbers were small, so that could be an artifact of small numbers. Maybe that's why the state doesn't show that. The spike here again was the ECU outbreak and spike. We came down into the single digits, but you can see since again about the end of October, we've been on a couple dips, but a relatively steady climb towards what will likely be our winter peak with this illness. The next graph shows the testing again. I did not put a line in at 8,000, but I did put a line in at 4,000 and 6,000 on this. And this is the estimated number of total tests per week that happens in Pitt County. And you can see beginning on 10/10, we have been pretty much at 4,000 or above, with many weeks before that above 4,000. Beginning on the week of November 21st, we've been at or above 6,000 tests per week. So if you look at that in a typical month, that's in excess of 24,000 tests per month. The state recommendation for testing in our county is to do 5% or have the capacity to test 5% of the population every month, which would be about 9,200 individuals in Pitt County. And we're testing in excess of 24,000 individuals in Pitt County every month. So I think we should be very pleased with how testing has grown, the availability of testing has grown. And again, the burden of testing has been spread across the medical infrastructure of Pitt County. While the health department continues to test in special circumstances and contact investigations, our community testing is over in favor of vaccination at this point, and it really has not led to a drop in testing numbers in the county as more and more medical practices come on with in-office testing. Increasing testing options. Again, testing will continue to be a part of our battle with COVID going forward. Received a call probably 2 weeks ago now from Dr. Morrow, who's doing some work on the state end at this time regarding the possible addition of a vendor-operated site in Pitt County, a test site in Pitt County. At this point, no option has been offered. I did request that the vendor provide weekend testing if possible, even if it meant having a couple of weekdays off, so that there was a viable testing option in the county on weekends. Right now on the weekends, some urgent cares are open. The hospital ED is open. We really try to keep, unless you need to go to the ED, want to try to keep people out of the ED. And if we had a freestanding test site that was open on the weekends, I think that would be of value to the community. So I did ask for that, but no guarantee on that yet. I will update you on that at our next meeting. Changing the viral landscape. this question has really kind of come up with several of us. You know, is COVID changing the viral landscape, or at least for this season changing the viral landscape? There's some evidence that COVID has actually pushed other viruses out, which in some ways is good news. It means there's more COVID, but it also means there's less of other things. Some of what we would normally see as seasonal viruses are currently missing in action. And thank you to Bill Cleve. Bill is the hospital epidemiologist. Every week, Bill sends a report out to a bunch of us on the viral surveillance that's done through the VMC lab. And this year, one thing that is just a glaring omission from a virology standpoint is something called respiratory syncytial virus. RSV generally infects children. In very small children, it can produce what we call bronchiolitis. These kids sometimes are sick enough to end up in the hospital. Rarely does it make kids sick enough that they die or have serious complications, but sometimes sick enough to be hospitalized. In adults, it really produces an upper respiratory type syndrome, a cold type syndrome when it does happen in adults. But to date, and that report comes out on Tuesday, so as of this morning, there have been no cases of RSV through the VMC lab this season, and the typical season runs from November through late December, and then it sort of peters out in early January, and we have not seen a case of RSV through the VMC lab this season. So that's good news again in this turbulent sea of COVID. That is good news. And influenza A, interestingly, by this time we're usually seeing a great deal of flu activity across North Carolina, but even here in Pitt County as well. With our seasonal influenza peak usually being around the second week of January. And to date, through the Vidant Medical Center lab, through VMC lab, we have only identified 2 PCR positive cases of influenza A this season. So there were great fears in the fall before flu season started about whether or not we would have to deal with both COVID and influenza. And while co-infection can occur, it is uncommon. And given the data from the VMC lab, it appears that influenza is not very active this season. So again, I think that's another bright spot in our in this sea of COVID. Want to fill you in on what's going on with contact investigation and tracing. There's so many facets to this outbreak. I wanted to hit these for you. I'm sorry to be so long-winded tonight. So what has Pitt County Health Department done? Internally, we assigned a contact tracing lead. That person is Toria Wilson. Toria's normal job is to do bloodborne diseases like hepatitis B, C, HIV, syphilis, those sorts of things. And when we needed someone who could coordinate a contact tracing program, we reached out and assigned Toria to that, and she's done a great job. So I want to give Toria Wilson a shout out and a thank you for the work she's done in this program, as well as everybody else who's participated in our contact tracing. We requested surge staff and received surge staff, from Community Care of North Carolina program. That's the state-funded surge staff program. There is no charge to us for that staff. Some of those folks are embedded at the health department. We generally have 2 staff that work 4 days a week at the health department doing contact investigation for us, and then hand it off to the tracers, which work remotely. We worked with ECU to develop a university-based contact tracing team, and we are in the process, or have embedded. I'm not sure if those people have actually arrived at ECU yet, but we are going to assign 2 of the newly acquired CCNC surge staff contact investigators to the ECU program to assist with contact investigation there and to make sure that data gets entered in a more timely fashion. We were behind. The investigations were done by ECU, but we could not get them access to NC COVID so they could directly enter that data. So there was a data backlog there. We have worked with Pitt County Schools to develop internal contact tracing in their programs. We work very closely with Dr. Lanker at the school district, Karen Harrington, his lead for contact tracing, and with our school nurse program as well. We have educated many local businesses on how to manage exposures in their own workplace. And for many of these, they get their first one and they're very nervous. We walk them through it. They get their second one and they've done most of the stuff right. Is there anything else we need to do? And we talk them through it. By the time they get their third one, they call us, and they've pretty much done everything they need to do, and they're just checking with us, and really, again, have tried to broaden and give folks the ability to defend themselves from this in their places of business and work. We've also worked across Pitt County departments. So essentially, we've become the company doctor for the county. Worked across many of our departments with other department heads on exposures in various county facilities and other county departments. So, and much of that has fallen on me and/or Amy. The state-provided contact tracing tool, sometimes referred to as the CCTO tool, provides automated messaging to cases and contacts entered into the system. At this point, averaging almost 157 cases per day, makes contact investigation tracing very difficult, and the state has issued guidance to us on how to prioritize contact investigation and tracing because there simply is not enough staff to do the investigation and tracing with the volume of cases that we have. So we are following that guidance from a state standpoint. Interestingly, in our own internal contact tracing, investigation and tracing, we've had several employees with COVID at Pitt County Health Department. We have not clearly had transmission in the workplace even before we were all wearing masks. There is one instance where transmission may have occurred between two Pitt County Health Department employees. I think it's likely, although at least one of those individuals had a source of potential exposures outside as well. So I believe it was likely to have occurred, but with this, sometimes you just can't say for sure that it occurred there. So if it did, that would be the only one that we've had. So we've been very aggressive in identifying close contacts of positive employees, quarantining them, testing them out of quarantine at day 6, and we have yet to have anybody, except in this one case, test positive in our internal contact investigation tracing. And so I find that interesting. There may be something we're missing in the transmission in this yet. I just haven't put my finger quite on it in this picture. Finally, review a couple of our challenges. Staffing, as Marcia mentioned, we have a number of vacant FTEs at the health department. At this point, averaging right now about 16 to 17% of our workforce is vacant. We have been able to supplement that with contract and volunteer staff, helping with the vaccine campaign. We will likely be hiring additional temp staff to help staff the phone bank that Amy's going to describe. We're exploring possibilities for deputy medical director at minimal cost. My time has become so divided because of administrative responsibilities and the great demands on the clinical side of me as also being the medical director, that we're looking at ways to provide some support to me for the medical director duties. And I have a couple ideas on that, but have not been able to contact the individuals who might be willing to do that role for us. Many of our staff, in fact, probably every person in the health department has multiple functional roles. In normal times, this is generally acceptable and people can do that. In COVID time, the volume of work is nearing impossible. It's making this nearly impossible for people to do multiple roles at this time. So we are struggling just from the volume of work, the volume of demands that are on the health department at this time. Kind of reminds me of the SEAL drown proofing, where you get thrown in a pool that's 15 feet deep and you got to bounce off the bottom and come up for air. And that's how I feel most work days are, that we're bouncing off the bottom and coming up for air. That's my report for tonight. I thank you for your attention, and I'm happy to take your questions or listen to your comments.
I have a question.
Yes, Dr. Hayes.
Okay, so you read in the paper that North Carolina's been given like 700,000 doses. We've only managed to administer maybe 150,000 of those. I hear from my folks here at the office that over at Viant, they announce on the PA that they've got vaccine available to give if anybody wants to come down and get one, and they're ended up throwing away vaccine because nobody's taking it because they don't want it. Some of them don't want it. And so I don't know how many doses have been thrown in the trash can, because it's only good for what, 30 minutes or an hour. Once you open the vial, it has to be used. But it begs the question for me is this strict protocol that we have for who gets the vaccine, when do we relax that such that we vaccinate anyone that's willing to be vaccinated if we have vaccine available and we need to use it? And I don't know if you have thoughts on that. I don't know if Dr. Garrison or anybody over at Viant can verify that, you know, they're having a hard time maybe getting people to get vaccinated, or I don't know, but that's what I'm hearing, and I just thought I would ask.
Yeah, Dr. Hayes, I'm happy to report that we have not wasted a single dose of the Moderna vaccine at the health department. In fact, the Pfizer vials are well known to have an overfill. They're supposed to have 5 doses and many of them have 6. We have found that not every vial, but often several vials of the Moderna will have 11 instead of 10. So we've actually been able to give more than what we have been allotted in our cases. When we schedule clinics, we are doing 1A clinics at the health department. Those are healthcare providers, the group 1A. We are working through that. We have had contact with over 80 medical facilities in Pitt County seeking vaccination for their workforces. So we are working through those folks. And from a capacity standpoint, remember, if we schedule X vaccines today, we've got to be able to do that, essentially double that number once we hit the 28-day mark. If we're going to do the boosters and continue the first shot in that series. I can tell you that to date, we've received 1,400 doses, 1,400 doses at the health department. By the end of this week, with our scheduled clinics this week, we will have administered about 1,160. And we're going to begin one thing I didn't mention was our mobile program with ECU Health Sciences to do the long-term care facilities that Paul Shackelford's helping lead on the ECU side. Dr. Shackelford and his crew are going to go out to do the first 2 long-term care facilities on Friday. We've selected 2 smaller facilities to let them test run the procedure and see how that goes. And then we'll expand out to other facilities. We're working with them. The consenting and approval process is a little slower with them, but we are working with them. I can't speak to Biden. Biden has both Moderna and Pfizer. Predominantly, their supply is Pfizer. We only have Moderna. Biden is working with ECU as a surrogate administrator to help get the balance of ECU physicians, medical staff vaccinated, and starting into some of the health science students. As I understand, I do not speak for Biden, so I'm reluctant to say too much about that. As I said, Dr. Hayes, we're working with them to try to stand up a joint large capacity vaccine center. They have received far more doses than we have as the local health department, but we have a great burden of A1s, and then with advancing to the 1Bs, which we did not expect to happen until early February, kind of shifted that timetable, about 3 weeks up. And we were informed of that shift on Wednesday, the 30th, and then didn't receive guidelines, the written guidance, until the afternoon of the 31st. So essentially on the afternoon of New Year's Eve, we received the written guidance for the phase 1B change. Does that answer your question, Dr. Hayes?
Yeah, I mean, that certainly addresses the health department aspect of it. And I'm not claiming that I know anything. All I know is what I hear. And so I know that the folks here that are on the Viant side would have better information than possibly what I know. And so I like to share what I hear. And if it's wrong, it's wrong. But I do know the rollout is challenging. And so I won't dismiss that. It has to be very challenging, but boy, it sure is slow. So I don't know. Viant folks, feel free to chime in. So
yeah, if I could, before the Viant folks chime in, with the Moderna, we have 6 hours once we puncture a vial to do that. So we book in groups of 10 if at all possible. We do have some county employees, other first responder type individuals who want the vaccine but haven't received the vaccine. we are keeping those folks kind of on a standby so that when we do have extra doses, we can find a home for those without and not having to waste the dose. We are constrained to follow the administration guidelines, so we do find county employees or other public service employees that fit those guidelines to provide the vaccine to, so that we don't waste it. Generally, our no-show rate has been pretty low with this, but we do have some no-shows, but we are doing our best not to waste it on our end. The Pfizer, I guess in the fridge, it can stay in the fridge for a week. I'm not sure how long it's good after you actually puncture a vial, Dr. Hayes.
All right, next, I think Ms. Pack Smith had a comment or a question.
Yeah, I had a question. So Dr. Silvernail, earlier in your report, you were talking about RSV and flu A and how those numbers, those reported numbers seem to be really low. Forgive me that I don't recall what's reportable from a communicable disease standpoint to the state. Are either of those reportable to the state? And would we find any other data being reported to the state that maybe is just not coming through the VMC lab?
Influenza is not reportable, Kelly. It's we follow that by proxy with what's called ILI, influenza-like illness. So those numbers come out of the ED and then what are called sentinel providers in the community. So a number of primary care practices, pediatric practices. I also believe RSV is not a reportable disease because it is so common as well.
Okay. And so potentially we could have other cases just not coming through the VMC lab, but they could have been, they're just going to be reported as ILIs as opposed to anything else.
Yeah, it's not saying that it's not out there, but looking at our previous experience, when we look at that surveillance that's been done for a number of years through the hospital lab here, we would normally expect to find many cases of RSV and also many cases of influenza that come up positive with that multiplex PCR that's run on the respiratory panel.
Great, thank you. Mr. Chairman, if I can just make a really quick comment to
Yes.
Dr. Harrell's, I'm sorry, to Dr. Hayes's question earlier. So, and I'm not going to be a spokesperson for Vidant Health. I will share that just like Dr. Silvernail, the health system is going to be constrained by those same requirements as to who can get what vaccine and when, or who can get a vaccine when. And so the healthcare workers are, without a doubt, our 1A, going to be our 1A targets. And as far as I know, there has been very, very minimal waste of vaccine. I have personally worked vaccine clinics, and I know that we will find folks to give that vaccine to before we will throw anything away. That of course is never the goal for us. But while we're still being told who we can vaccinate, there are always going to be challenges with making sure we're getting it to the folks who are eligible to get it and those who want it. As long as it's not going to be a requirement, we're always going to be challenged with, people being vaccine hesitant, and that's a whole other conversation to be had. But I can say for sure that the health system is doing nothing but trying to push the vaccine to who it is approved to give it to. And as Dr. Silvernail stated, there are some plans in the works to get more vaccine out into the community. So even if it's sitting at the hospital or the health system or other hospitals in the region, there are going to be those collaborative efforts to make sure it gets into the community if it's not being used for healthcare workers in the hospital walls.
Thank you, Ms. Pack Smith. I think Dr. Engelke was up next with a comment or a question.
Yes, can you hear me?
Yes.
I have two questions based on questions I've gotten from people about the vaccine. The first one is related to allergies, and people who have severe allergies in the sense that they carry an EpiPen for something that is not one of the two things that's in the injection or the other substance you mentioned. They are eligible for the vaccine and should schedule it.
Yes, Dr. Engelke. Allergy is a relative contraindication, not an absolute contraindication. So as part of that medical screening that all of these vaccine candidates go through, we review their allergies, even if they've marked nothing to make sure that there's not a history of anaphylaxis. If there's a history of anaphylaxis or anaphylactoid type reactions, those individuals are held for a 30-minute observation post-vaccination, where everyone is required to be held for a minimum of 15 minutes post-vaccination. Those folks who have a history of significant allergy are held for at least 30 minutes.
Okay, great. And then my second question is that unlike other states where the age that they're considering 1A is 65 years old, North Carolina is deciding that that is 75 years old, is my understanding. So people who are between 65 and 74, are they now just a part of the general, you know, as we move through the other, they're not healthcare providers or anything like that. Are they now part of the general population?
Unless they were otherwise eligible through occupation, they would fall into, I think, what is now Group 1C or Phase 1C.
Okay.
And again, that guidance is something of a moving target, Marty. So
Yeah. Someone told me they were going to Florida because it's 65 there.
So yeah, that guidance is something of a moving target. And it's also open to some interpretation, and even from the state health director, where she said, well, if it's a provider who does CPR, then that's Group 1A. Well, all of our sheriff's deputies, our road deputies, carry an AED in their car. So they're all considered first responders for cardiac arrest. And so they provide CPR. So are they 1A or are they 1B Group 2? They don't do CPR every day, but they might do CPR from time to time. So there's some interpretation of the guidelines that can go on in some settings.
Okay, thank you.
You're welcome.
Oh, you had a question?
I just wanted to comment on the Biden clinic. I can't speak for the clinic, but what I can tell you is that it dumps right outside of my office. And so I see people coming out of there, and it is rather busy. And so it kind of made it sound like it was like not a lot going on there, but there's people rolling through there pretty constantly. So if there's some waste, I doubt it's much. I mean, at the end of the day, there may be, but they're rolling people through there pretty well. So certainly there's a lot of people getting vaccinated in the hospital. I just want to make that comment.
Thanks, old Dr. Garrison.
Thanks, Adam. First, a question for John. The no RSV and very little influenza A is just remarkable. And you mentioned overcrowding by the coronavirus. I've heard some speculation of mask and distancing may also contribute to that. What are your thoughts on that, John?
I do. I think that's part of it, Dr. Garrison. Certainly the things that we're doing to impede the spread of COVID would impede the spread of influenza. So I think that is definitely part of it. With children, kids are usually pretty good at swapping viruses. So I'm not sure that the social distancing, masking, the hygiene issues are as effective in kids. But it's interesting that we just haven't seen a case of it through the hospital lab this year, where normally we see tons of cases through it and through the ED. And same thing with influenza. Normally, we see a number of cases that come up positive on that respiratory multiplex test that's run in the ED and through VMG offices. And it's interesting that here we are, it's January 12th, and we've had 2 positive influenza cases. I wouldn't be surprised if that was the surveillance from September, but surveillance from January, usually we've got, we're looking at a community rate of, probably something like 5% most flu seasons. Of the community would have 5% of people on that ILI curve, meaning 5% of people through the ED and the Sentinel clinics would have the influenza-like illness criteria in their admission criteria to the office or to the ED. So I find that interesting.
And then if I could just respond to Dr. Hayes's comment, I think Dr. Hayes speaks for a lot of people who are out there thinking and saying, I'm ready to get vaccinated, bring it on. And I think that's a very reasonable thought and need. And I was comforted a lot this morning, Mark, in a meeting I was in where there were leaders from Vidant, leaders from the university. I know that they had been in communication with John and Amy, and it was the first time that I felt really good about we're going to be able to get some vaccine out soon. I mean, they were talking about some big plans that I know John and Amy know about in terms of standing something up. And I think some of the reluctance has been, let's don't open the gates until we know we're going to have a lot of vaccine. And I think there's not been assurances from the state and from the feds that, okay, we're ready to give you lots and lots and lots and lots and lots of vaccine. And I think that's where the reluctance has come from. But it really comforted me this morning to hear the plans that are in the offing. And I think you're going to be happy sooner rather than later about what's going to happen.
Thank you, Herb. I just, I know that my staff, we're not viewed essential, okay? In Virginia, veterinarians are getting vaccinated. But in North Carolina, our guidelines, we're way down the road. I mean, we're way down. And for reasons that I sent an email to Dr. Silvernail, and I understand, I certainly do not have the face-to-face contact that human healthcare providers do, being that we now leave our clients out in the parking lot, but nevertheless, some of my staff do. And so I would be very happy to have my staff on a call list to come over there if you have any extra vaccine and get them vaccinated. I hate to think that vaccines not being used. And I look forward to the day that they push it out faster to those that really do want it. And I know they have to have a plan in place, and you have to have a system in place. And until both those things are in place, then having the vaccine really doesn't do any good. So, but I'm glad to hear that. That's reassuring.
I had a question, Dr. Silvernail. Would you say from the health department standpoint, the biggest limiting factor right now is physical space, time, or number of vaccines?
Dr. Harrell, we are definitely limited by physical space. Most of our planning scenarios for mass dispensing are based on the anthrax scenario or other bioweapon scenario where we need to give Cipro and Doxy, and patients are not communicable when they come through the dispensing site. The other scenario that these plans have been built around is pandemic influenza. And again, people are not generally infectious unless they're sick with influenza. So with COVID, we're doing this under a socially distanced model. So we've had to cut capacity down in these dispensing operations, make sure that we have adequate spacing for the vaccinees while they're receiving their education, while they're receiving their medical screening, while they're getting their vaccine, and then the hold period on the back end where we've got to hold people for at least 15 minutes and perhaps 30 minutes. We didn't talk a lot about the details of our operation on Monday. We booked 8 people every 15 minutes, and they got their education beginning in the cars when they parked, got their paperwork so they could work on their consent paperwork and their medical screening questions. At the appropriate time, they were brought in through the side door of the Ag Center, brought into the auditorium where they went through the medical screening station, and then were escorted to socially distanced vaccine stations. They received their vaccine. We basically, for most of them, we held them right at that spot. We had egg timers or other little kitchen timers for that spot. It was set for the 15 minutes, and when it rang, the nurse checked on them and they were discharged. If they were held for 30 minutes, excuse me, we had a separate area where we moved them to with a TV playing a message from Dr. Hardy regarding the vaccine on a loop, and they were held for the 30 minutes in that area. A higher percentage of the 75 and older age group received the 30-minute hold than our typical healthcare worker group that comes through the health department. it's a relatively small number. It wasn't a huge number, but it was certainly more than when I've run the clinic, been working the clinic at the health department. We're doing healthcare workers and first responders, that 1A group where we might have a couple of people in each batch or one person in each batch. But here we had several people that were in that 30-minute hold at a time, waiting to work through that. So a larger physical plant would, if you're going to increase the capacity of that clinic, a larger physical plant would be needed so that you had more space for these folks. You would also need more vaccinators. Given the vaccine is actually the shortest part of this, it's the front end, the education and screening, and then the hold on the back end that are really the time consumers. If we were given tetanus shots, we could run a ton more people through, but we're not given tetanus shots. We're given vaccines to people who themselves may be communicable, and we have to handle them as such.
Thank you for that. I think you had mentioned that Amy had some information for us after.
Yeah, if you're all done with questions to me, Amy's going to fill you in on the plans for the scheduling system going forward. Amy, are you ready?
I am ready. I did want, before I move into the plans going forward, I did want to add a few comments about Monday's clinic. I really wanted to give a huge shout out to all of our staff. We pulled this clinic together in about 4 days once we realized how much vaccine that we would have available for the 1B group. And it really did run seamlessly. We had about 40 support staff in addition to our nursing staff. We also had nursing staff from the ECU College of Nursing, and we had a few retired nurses that came back to help us on Monday. As Dr. Silvernell said, we did schedule about 8 appointments every 15 minutes, and I'm so elated to share that we had 100% show rate from all of our appointments. And it's also addressing the wasting of vaccine. We did schedule 224 appointments, and since some of the vials we were able to get extra doses out of, we had 6 additional doses that we could administer. We called our hotline staff to ask if there were any of our community members who didn't make the cutoff when we cut off the appointments last week. And there were 2 that were able to come last minute to get 2 of those doses. And then we reached out to our 1A healthcare workers that could quickly get there. So we were able to actually provide 230 vaccinations without a drop of that wasted. Also wanted to give a big shout out to the Pitt County Sheriff's Department, who did a great job of keeping traffic control. They only allowed individuals in the complex during their appointment time, very careful to make sure others did not get ahead of others. And then our National Guard members that have been working with us for the last few weeks helped us to corral patients in parking spaces that were coinciding with their appointments. So happy to say all that went very, very well. Some of the frustrations from the community, we put out a news release last week telling the community that we were going to have a clinic on Monday. Within 3 hours of putting out that news release, we had filled all of the 224 slots. We have 4 phone lines that were running in our hotline, and it was all we could do to answer the phone calls. They came in so rapidly and continued to come in. Many were upset because they could not get through. We were reluctant to take a sign-up list because we did not know when we were getting vaccine, and we didn't know if we had the capability of reaching back out to the community to schedule appointments from a list. So we have heard the community. We know the community's been very upset and not able to get through, but the overwhelming call volume has almost caused our hotline system to crash. Today, if you called, you might not get an answer at all, or you may get a busy signal. So our MIS department under Mike Taylor's direction, also want to give a shout out to Pam Black and Pam Davis and Brad Black, who have been working with us to find a remedy to this. And so where we're going from here, we have now installed 10 additional phone lines in our emergency operations center located in the county office building. And thanks to Randy Gentry with emergency management for leading that. We are going to use those 10 phone lines as an appointment hub so that those calls are no longer coming through our hotline. The hotline will, going forward, will be now used just to answer questions about COVID, as it was originally intended for, and all the appointments will be filtered through the phone lines. However, the way we're going to go to the appointment system, we are going to implement an online wait list. And Mike Taylor was guiding me through this today. So I think you're on tonight's call, Mike. So thank you very much for that assistance. I told him he talked me off of a ledge today because we really wanted to make sure we reached out and served our community. So our goal is to have an online sign-up list ready by this Thursday, January the 14th, and it will be available on our website. Right now, it will be for the 1B 75-year-olds. We will keep changing that as we're able to provide additional vaccine to other groups. And then from the form that they will fill out online, MIS will then create a database for us that we can then give to staffers in the phone bank that will call individuals in order that they're on the list and schedule them for an appointment. They will not be in the phone lines every day. We will have the phone lines only open once we have vaccine and we have scheduled appointments or clinics. We have scheduled the cooperative extension building for many, many days throughout the rest of this month and into February. So it is on hold for us so that we can quickly set up clinics as soon as we know how much vaccine we can offer to the community. I also received confirmation today from our county finance director, Brian Barnett, that we will be able to hire temporary staff to run the phone bank so that our educator staff that have been running the hotlines can continue to do that and provide that information, answer those questions to the community. So we'll be working on that very soon as well. And then another element we're adding to this, Carla Hansen, who is our interim public information officer, our director of public information, she is going to send out a news release very soon to remind the community that you can subscribe to our website. So anytime we update the website, they will receive a text message to let them know that an update regarding the vaccine and any plans going forward, they can receive that through a message. So thanks to Carla for helping us to work that out. And I also want to mention to the community, if we're not returning email quickly enough, we do apologize. We have email coming in from our coronavirus email, our Pitt County Health Department email, my personal, well, not personal, but my work email that comes directly to me. Both Dr. Silvernail and I are getting numerous emails. We're not as quick to respond right now because it's been all hands on deck to try to improve our service delivery of offering the vaccine. So we'll get caught up soon, but we did want the community to know that. And then also going forward, we are working on a second public service announcement. The first public service announcement that we released just before Christmas featured all of our leaders between city and county government to encourage individuals to follow the 3 W's, wear, wait, and wash. And now the second video that we will be soon producing will reach out to our African-American community. We did not have a large participation from our African-American community in our clinic yesterday. So we're trying to reach out to this population to encourage more sign up to receive the vaccine. So we've been working with some of our leaders in the community to help us with messaging for that. So I hope that will be the next thing to come. And that's it.
Dr. Garrison had a comment, question.
Yeah, thanks, Amy. And I think it's just incredible the job you are doing. So I'm glad you handed out all those thanks and stuff. Whenever I hear the W's, it reminds me of when I was a medical student learning about the 4 or 5 W's that cause a post-operative fever. Wind, water, wound, walking, wonder, drugs. But we have different W's now. So John, I think the federal guidance lowered the threshold for the 1B group or the older age group from 75 to 65 this afternoon. And you mentioned it then goes to the state and then comes to y'all. Could you describe that again, how we would change our threshold and stuff?
So at this point, Dr. Garrison, when we signed our COVID vaccinator agreement, we agreed that we would follow the state prioritization guideline. So we are kind of stuck with the state prioritization guideline as it stands. We actually, I think there were a couple of calls to the department today about the 65-year-old age group. And that may be what Dr. Tilson was hinting at this morning in terms of an impending change. If that age threshold is lowered in that system that Amy described, this online form, we will allow that to happen. The rub is still the vaccine. You know, as I said earlier, we don't have a dose for everybody who is eligible under the guidance provided. And so by the end of the week, we would have a little over 200 doses left. Much of that committed to long-term care facilities, which is going to start on Friday with Dr. Shackelford's mobile team that we've worked on. And then going into next week, we look at having about 600 doses if we get our allotment this week as promised. We would probably split that 50% because we still have a large number of 1As. So we split it to the 1As, you know, 50% to 1A, 50% to 1B. So that'd be 300 doses for the 1B group. That's still a drop in the bucket when you consider that in Pitt County and the 75 and older is in excess of 9,000 individuals. If we go to 65 and up, I don't have a number on that one for you, Herb, but it's certainly going to double that, if not more, in Pitt County. So 300 doses is not going to go very far in that population, unfortunately.
Thank you all for everything.
I did want to add one more thing. Dr. Silvernails reminded me that ECU Student Health Services, they also participated with us at the clinic yesterday. So I want to give a shout out to those representatives as well. A lot of support.
Thank you, Amy. Dr. Silvernail, I did have a quick question about, can you quickly touch on how the state went about setting a number for each county on just the gross number of vaccines that would be sent out?
Honestly, Dr. Harrell, I'm not sure how they came up with a total number for the county. My understanding, and that math just doesn't seem to work based on some numbers that I heard from Viden earlier, was that the healthcare system would get 60% of the county's allotment and the health department would get 40% of the allotment. Based on a number that I heard in terms of the Viden vaccine receipt, that math just doesn't seem to work. So that process is a little mysterious. Right now, the state said today that they only have allotments guaranteed through the end of the month is the other thing. So they do not have an allotment schedule for February yet. They have allotment schedules for the next 2 weeks or 3 weeks here that's left in January, but there's not an allotment schedule for February yet. So that probably just hasn't been released from the federal government. If anything, vaccine supply is supposed to be getting better, not worse. But that does that certainly gives me some heartburn, some agita here that you know, we're struggling with a relatively small number of vaccines, trying to get these into our healthcare providers and protect our healthcare infrastructure, and then trying to protect our most vulnerable citizens, and then not knowing going into February, not knowing what we're going to have. And one of the things that we've struggled with from a planning standpoint is, you know, we were told to plan for a vaccine campaign. We didn't know which vaccine we were going to get until very late in the game. We didn't know how much we were going to get, and then we didn't know when we were going to get it. So it's very hard to plan. We also thought we had been told that we would likely not start any community vaccination until early February. So when we set up our 1A schedule, we built a 1A schedule for January, not with something called Sign Up Genius. On our end, it's a two-part process. This COVID vaccine management system from the state was rolled out on December 10th. It's been through numerous upgrades. So, you know, every time an electronic health record goes through an upgrade, you basically have to relearn it. It's been hard enough to get, you know, one person to learn it, let alone more than one person to learn it. So we are struggling with data entry on that. We have been manually updating our inventory by sending the number of doses given to the pharmacists at the state so that we continue to get our allotments. But they really want that data in CVMS, but we are struggling with that based on the upgrades in the system, and then our staff's lack of familiarity with it. And many other local health departments are struggling with getting that data into that system as well.
Quick follow up to that. You made me think of another question.
Originally, we were told that if we got 100 doses, that was 50 courses, and we had to bank for the second. As we moved through this vaccine from when we first started talking about this in the fall to getting closer to allocations, we were told that that is pre-booked in the allotment process. So if we get 900 doses the first week, when we get to that fourth week and we have to do those boosters, we should get 900 doses to do those boosters with. It is a little bit of a rolling process, but we don't have to hold vaccine for the booster dose. The state is telling us that that is being done on the federal end and will be handled through the allotment process, so that we should have adequate vaccine to cover booster doses and new doses going forward.
Great, thank you. Any other questions or comments from the board members? I think.
This is Lowell. I'm sorry. Hey, two things. One is that I did have a family member go through the vaccine. I sent an email that he gave it an A+, and that's a big deal. So it really went great. But how is morale of the department? I mean, I know they're getting worked hard, and I don't want to see people leaving. That makes it even worse. So how is morale? Is there anything we need to do or can do as a board to help? I sent that email just trying to tell them the truth, but no, they're doing a good job.
Trying to answer that question, Lowell. I think overall our morale is good. We are tired. We are beat up. Myself and most of my senior staff have not had a day off since last February, or a meaningful day off since last February. While I've tried for most of our employees to keep their work life as normal as possible, that's not always possible in COVID time. I think we all left that clinic yesterday on a high. We really felt great. People were very complimentary. In fact, your family member was personally screened by me yesterday, coming through the clinic, and so he got his medical screening with me yesterday, and I enjoyed it. I really enjoyed working that clinic yesterday. It ran very well. The concept was sort of mine, but then I handed it off to Amy and our nursing staff to flesh it out and make it happen, and they did a fantastic job of refining the details of my very crude conceptual plan. And we're a team. We're a great team. Fortunately, I have a great team of folks that I work with, and I would say the morale is good. We do sometimes feel like we're getting beat when we get our staff gets fussed out by folks, and we get fussed out by folks, and like I said, 300 doses is not going to go very far in a population of 9,000 plus. And if the state drops its age to 65, that'll only increase the demand while our supply is held constant. So I see there's going to be more frustration in the community, which will undoubtedly be taken out of myself, my leadership staff, and my employees. I had a terrible thought one day, and actually sent this out to a couple of my health director colleagues, and that normally when you're running an operation, part of the planning department's job is to plan for the demobilization from that operation. And that would fall to my planning chief, which is really my new preparedness coordinator. And I certainly don't expect her to write a demobilization plan yet. We're nowhere near being able to demobilize from this operation. But I am very fearful of what our health department and what the healthcare infrastructure across the community is going to look like on the other side of COVID. Everybody is tired, everybody is beat up, everybody has worked at 110% or more for the better part of a year now, and it's taken its toll physically and mentally on the healthcare workforce. And I think when we get to the other side of this, people who can retire may very well retire, and I think we're going to have some departures from our department for folks that are eligible to take retirement leave. I'm sure in the Vidant workforce, that'll be the case, and across other healthcare institutions that will be the case. So part of our planning going forward has to be for the rebuilding and restoration of our healthcare workforce after this enormous and lengthy response.
Thank you.
I think what I would like to do, whether they come from me as the health director from the Board of Health, on the other side of this would be to do some sort of commendations and recognition for the work that our employees have done through this emergency.
I agree. I think that's certainly in order. Other questions or comments from the board?
So this is just a comment and only speaking for myself, but John, if you needed us to have any policy that would provide you cover such that it's not you taking the brunt of the public and you can say the board made me do it, I'd be happy to support something like that.
I'm a big boy, Dr. Garrison. I'll take my lashes when lashes are owed, but I appreciate that.
All right. Seeing no other questions or comments, thank you again, Dr. Silvernail, for unpacking that information. Certainly a lot to know on there. We will seek a motion to adjourn from a board member.
I move that we adjourn the meeting.
Second it.
And if none are opposed, we will see you next month.
All right.